Yes, yes.
Yeah.
Now,
And we can see. Yeah.
Okay, so thank you, organizer, and particularly thanks Tapash and Dr. Padi for giving me this opportunity. As mentioned, I'm just going to talk about some of the perception about ECMO. Are they really true or not? In next probably 20 to 25 minutes. I do not have any disclosure except for the fact that I'm a strong believer of ECMO and its capability to change the lives of many critically ill patients in most of the hospital setting. I hope by the end of this talk, you will be able to know some of the clinical applications of the ECMO and how we should plan to improve the outcome of the patients, those who are supported by this extracorporeal technology. The myth number one is there is no difference between the cardiopulmonary bypass and extracorporeal membrane oxygenations. If you think about extracorporeal membrane oxygenations, it's nothing but a younger brother of the cardiopulmonary bypass machine. But what we have done over the years, that we moved these cardiopulmonary bypass machines to the bedside and trying to help many of the sick people, those who have problem with heart and lungs in general. So this is a simplified circuit version. Both of this technology, cardiopulmonary bypass as well as ECMO, has been there in the arena of critical care world since mid 20th century. What we do, the principle is same in both. We took the deoxygenated blood from out of the body and then oxygenate them and then return it back. The major difference is here, if you think that this is the extended version or larger version of the cardiopulmonary bypass machines, which usually helps the people to underwent cardiac surgery in the operation theater. And the difference is, one, that they have a large reservoir, which we do not have in ECMO at the bedside in ICU. They have many suctions, machine, vent, and cardioplegic solution which can be utilized. So in general, the complexity of the cardiopulmonary bypass to support the cardiothoracic surgery in the OR is much more stringent and complex and need more expertise. And this is what you can see in the OR if you ever. But ECMO is simple. If you can see that my colleague is holding this 20-pound machine. There are many forms of machine now in the market, but this is the machine which came to market back in 2009 and completely revolutionized the practice of ECMO for the last 1.5 decade or so. So coming to the modality, as I said, depending upon which organ we wanted to really help, that's what the types of ECMO. One, if we are related to help only the lungs, then it's called veno-venous. If we wanted to help both the heart and lungs of the patient at the bedside, then we call it veno-arterial ECMO. And there are many combinations. Please have a look on the literature mentioned on the slides for detail. So what is the perception then? Is there any difference between the cardiopulmonary bypass and ECMO? The answer is yes. So they have different indications and there are different modes and how you manage the patient. So that's what's the final thought on this one. Coming to the next one, this is called ECMO supported patients outcomes are terrible. In other way, people think that those who goes to ECMO in the hospital or in particular in the ICU, all of them are going to die. Some people also say that ECMO kills everyone. So remember that our view of the world in general is mainly based on many flawed stories, because whatever we hear from the people, we often don't confirm them and then keep on believing without trying to see whether our assumption on what we believe is right or wrong. This is being very nicely described in one of the book called The Black Swan. Please, if any of you have time, it's a wonderful book to read and see how the world functions and how we believe. So in general, what I'm going to talk is that the critical care in general has a very close correlationship with the pandemic. The critical care as a subspecialty of medicine started back in 1952 when mechanical ventilator was invented to support the people, those who have respiratory failure because of the polio pandemic. And then ECMO in general, despite its availabilities in mid 20th century, get its attention or got its attention in 2009 H1N1 pandemic. And now we are still coming or maybe going through this largest pandemic of our life so far, the COVID-19 pandemic. And we all knew that possibly ECMO has a significant impact in the lives of many people. I would say that probably we should be thinking ECMO as a new mechanical ventilator moving ahead in next couple of decades. How is that? Because if ECMO kills everyone, so do we have the evidence? So if you go back to the initial part of the pandemic, this is a Lancet study. So it has shown that people, those who have severe ARDS and supported by ECMO, they do have better survival than those who are not supported by ECMO. And in the last 3 years or so, we have many papers. So that's probably ECMO has made a difference in the lives of people, those who are lucky to have the ECMO support, because most of the facility do not have, and that is from different parts of the world. Not only that, if we move to the other part of the clinical problem where ECMO has made a significant impact in the cardiogenic shock. This is a graph showing the cardiogenic shock causes where ECMO has a significant improvement or has made a difference. Mostly the two, one post-heart transplant cardiogenic shock or myocarditis patients. We have data that if you support this patient yearly, and in particularly in selective patients, it has better outcome than not supporting the patients on ECMO. And the other area where it has shown some promise is particularly cardiac arrest patient. There are two recent randomized controlled trials, one from United States and the other one from Europe. It has shown that if you support the patients, those who have cardiac arrest by ECMO, their outcome is far better than those who are not supported. So in nutshell, ECMO doesn't kill everyone. It has some significant impact. So this is a myth. And I believe that we should not say that ECMO patients' outcomes are terrible. So this is about the perception which needs to be redone or things in a different way. Coming to the next one, which is often the challenge, which called the ECMO is resource intensive and is a costly business. Is it true? Let's see where we stand for here. So before I jump into the give some data, I would say that we should not put too much of stocks in rumor, and also before we believe that we have to deep dive into the various interventions we do in the bedside for the patients during our ICU practice. So what is that? There is a two concept to really know that what is the value of our intervention in general. One is the cost-effective analysis. The other one is called I-share or incremental cost-effective ratio. It's more kind of mathematical model, but what is recommended that if you think about what is the cost of neo, what is the cost of the reference interventions, and then you adjust with the quality of life in general, you will get a number. And various institutes like Institutes of Clinical Economic and ACC, AHA, the American Heart Association, and WHO had the number with respect to the quality of life in dollars value. Like most of the times, if your interventions or limits within this is range, that is supposed to be a good intervention in general. So when we come to the ECMO studies, like ECMO trials, and then they analyze, it has shown that the Caesar trial, which was published in 2009 and changed the practice of ECMO in general across the world, the US dollar is 28,000 or 30,000 per quality life. Similarly, the other studies from Australia and sees that the numbers are within the range of $100,000 quality of life expectancy. So I'll give you some example of the ECMO versus other therapy with respect to this number. So these are, let's see, one is ARDS. If you just put the patients on ARDS mechanical ventilator, how much money or how much dollar we are spending. And then this is in comparison to ECPR. This is about the ECMO in the neonatal ECMO. That is about the TAVR, like see the numbers also here. Intermittent hemodialysis, 85, and also CML chemotherapy, 50. Flu vaccine for the health workers in a generalized or large hospital, 35K. So in general, if we see that the numbers are not different, though the incremental cost, the asking cost of ECMO support in the hospital is high, but if we are smart enough and manage the resources at the hospital, then it is probably similar to many other day-to-day practice or day-to-day interventions in the ICU or in the hospital. So this is a myth. Yes, probably it is costly, but it's not relevant when you look into the life it saves, and it helps the overall people's and then societal improvement if we save one life. Myth number 4, ECMO cannot be done in people those who have bleeding because of the trauma or from other reasons. Is it true? So the available, I would say the available ECMO machines as well as the tubing, everything does ask for anticoagulations. And if we go back to the complications, the most feared complication of ECMO practice remains the bleeding as well as thrombosis. So there are many methods, and people are looking into what are the ways we can really prevent the bleeding and thrombosis in the ECMO practice. In our practice in Mayo Clinic, we primarily have the practice is based on thromboelastogram, and we mostly keep our patients on bivalirudin, depending upon our experience for the last, I would say that 5 to 6 years. We are moving away from heparin. That's not the truth for many other centers. But that's the question is, can we practice or support ECMO in patients with bleeding? This is a analysis of also registry from 90 to 2016. They found out that ARDS patients, those who have mainly traumatic ARDS, BV ECMO has 63% survival to discharge, and VA ECMO 41%. And there are many case reports as well as case series from the battlefield ECMO applications, particularly from the US and then Europe. So in nutshell, yes, ECMO can be utilized in patients those who have bleeding if we are careful and monitor where we are going. It's not an absolute contraindications to be sure. So this myth, which is like it's absolute contraindication, not really, but we need more data on this too in future for sure. Then myth number 5, ECMO supported patients cannot be mobilized. That means they will be always hooked into the bed and sedated, paralyzed, you name it. That's not the truth. This picture probably says you or says everything what we can achieve with ECMO. This is Dr. Chaudhary, one of my colleagues, who is also a speaker on this conference, and our ECMO team. And we are mobilized. This is a regular phenomenon in our ICU with the help of our ECMO specialist, the physiotherapist, respiratory therapist, and ECMO nurse in general. And there are many studies which is like coming one after another over the last 3-4 years that it is feasible to help the people, those who are supported on ECMO in the mobilizations. The things which we need to be careful about the patient selections and then type of ECMO, particularly if you have an open chest and veno-arterial ECMO cannulations, then you have to be careful because that will be a disaster if there is any dislodgement of the cannula. But in general, the concept that ECMO patients cannot be mobilized is not true. Rather, it is very patient-specific as well as also time-specific practice. Initially, when the patient comes out of the OR, from the ECMO. You may not be able to do that, but as the time passes, it's feasible to mobilize the patients without having any problem. Myth number 6, ECMO patients ECMO patient doesn't need mechanical ventilator support. So this is always being said that once you put the patient on ECMO, why we need to put or continue the mechanical ventilation? While it seems like intuitive that if ECMO can support the heart and lungs, or maybe just in the respiratory failure lungs, then why I need to keep the mechanical ventilator for sure? As we know that the concept that when we go to positive pressure ventilation, the main culprit of the complication related to the positive pressure ventilation is the ventilator-induced lung injury, and we need to avoid that for all practical purpose. And then how do we do that? Like we don't have a clear-cut way to like shift the gear going from positive to negative ventilation. ECMO can help you to extubate so that you go to the normal ventilatory strategy, which we call the negative pressure breathing. But the problem with mechanical ventilator while the patients are on ECMO is that it can be problematic because of the underlying pathology for which the patients are on ECMO, and as well as also there is a risk for emergent intubations if something happens. So this strategy of mechanical ventilation on ECMO practice is really the area of research right now, and then patient selections in general. So what can be done? So I would say that yes, possibly they don't need mechanical ventilator support, but not all the cases. So be careful about what is the patient's underlying pathology. Is it because of emphysema? Is it because of hypercapnia? Is it because of the hypoxemia? Is it ECMO is for the cardiogenic shock? So all these things, in fact, needs to be considered before we think about to extubate the patients and just go for spontaneous breathing. The next one is ECMO initiation is only limited to hospital setting. What is it says that people think if you are going for a resource-intensive extracorporeal therapy, the only place you can achieve this goal is within the perimeter of the hospital. But that has been challenged with the recent practice. As you can see on this picture, ECMO has been deployed in the F-16. This is the Paris subway where people are trying to put the patient in ECMO. And this is where the pictures, you can see that where are the places people are practicing the extracorporeal life support mechanism for helping this, helping many people. And the most promising aspect of the extracorporeal therapy is the ECPR in out-hospital cardiac arrest, as I shown this picture before on my talk. This is the 2 trial. That is the 3rd trial just published a couple of months back. The take-home message is that ECMO can be deployed outside the hospital if you have a practicing and well trained team, and that is being done first time in Twin City, Minneapolis. As you can see this, there is a group of researchers as well as physicians. When there is a cardiac arrest, in addition to the rescue team and police, the ECMO truck goes to the site where the patient is having cardiac arrest, and they try to cannulate and move the patients to the hospital. So in nutshell, ECMO initiation is not only limited to the hospital setting, it can be expanded out of your hospital perimeter. And I believe that this is the future and where ECMO is going on with the simplification of the technique and then the experience we are getting how to manage these people. And possibly, as I said, the ECMO will be probably the next mechanical ventilator in another decades or so. The next one is ECMO should be the last resort for cardiorespiratory failure. So this is kind of a myth or debate in the literature on the ECMO believer and non-believer, that at what time or when we should call the ECMO team to the bedside. So is it yearly prophylactic, or we should be waiting for the last effort from your team. You have completely gone for the 10 different inotropic support, mechanical ventilator, proning, and paralytic, or some experimental therapy, dialysis, or should we call for ECMO initially? Remember that at this moment, to support one versus other approach, yearly prophylactic or late therapeutic, or the middle ground that possibly found out a predictive model to support the ECMO, support the patient by ECMO, is very, I would say, primitive, because we don't have a large-scale randomized controlled trial. We don't have a universally adopted practice methodology, and there is no clear consensus about the fact that ECMO can make a difference in various cardiorespiratory failure. So there is no ideal solution, but you have to understand that what are the rationale why we do what we are doing at the bedside, particularly in relations to the extracorporeal support. There are three areas, as I outlined there, where ECMO has been shown to be beneficial. One is ARDS patient, the other one is shock, the third one is cardiac arrest. And all these three scenarios, the conventional strategy to help the sick patients are stagnant over the last 10 to 15 years. The severe ARDS patients, mortality remains 50%. When the patients are coming to the hospital with cardiogenic shock because of atherosclerotic cardiovascular disease, and if they require any mechanical circulatory devices, their outcome is dismissal. Still 50% of people die. And when the cardiac arrest, we know that almost 80% of the people, those who have cardiac arrest, could not, like, they succumb to the illness in the hospital. And ECMO has the potential to make the difference in this group of people. And I believe that ECMO has a middle role. We should not be thinking as the last resort, because once the setting for multi-organ failure starts in your patients, then the chances of getting a good outcome diminishes as the every hour, every minute. So we have to be careful in the patient selection. Myth number 9, ECMO is only temporarily. So when we think about ECMO in general, there are three concepts we need to really put in our mind. One, ECMO is not a treatment, it's just a support system similar to mechanical ventilatory or the extracorporeal system for the cardiogenic shock. So we have to have a exit strategy, and also knew that at some moment the patient will need anticoagulations, and then ECMO at this moment or at this time is not supported for years. The maximum ECMO support in the literature is 720 days. So that means it asks for that why we are really considering to put our patient in ECMO. Is it bridge to recovery, that the underlying patient has a pneumonia or respiratory failure? We feel that it's going to be improved and our mechanical ventilator strategy is not enough, so we need to support the patient on ECMO. Or we are taking a bridge to decision making, that the patient was found down in your hospital lawn or garden, and then there is nobody with the patient. We are supporting the patients for the cardiac arrest. Maybe the family will come and take a decision. Is it appropriate for them? Or maybe we'll give them a justice that they see their loved one while they're alive, even if they are not interacting. So in nutshell, that we have to find out exit strategy. This is what the principle we practice, that we don't go when we are called to put the patient on ECMO, we don't go to the idea that, yeah, we'll put the patient. We go to the idea that what are the exit strategy, because we know that ECMO cannot be supported for the patient forever. So I would say that yes, at this moment, ECMO is temporary, because probably the future will be different, like the long-term mechanical ventilatory support that needs many changes in the machine as well as the practice prerogatives. ECMO long-term outcomes are not good. So what does that mean? So I said that since 2009, the practice of ECMO has significantly changed, but do we know what are the outcomes? The outcome of ECMO is mostly coming from the pediatrics world. There has been some report, as this one came from a large population-based studies, that the survival of the people or survival of the patients, those who are supported by ECMO at 1, 2 year, 5 year is like hovering around 40 to 50%. What is the data for adult populations? This is also kind of say that 1/3 of the people at 5 years are survived while they are supported by the ECMO, both VA and VV. But there are many limitations with PTSD, like similar to other things. But what is needed is more data to really have a conclusion. So this means I would say that yes, probably the long-term outcomes are not good, but we are not sure at this moment. Maybe with this ongoing pandemic, with large number of people, those who are being supported, if we have longitudinally follow these people, will have more ideas. ECMO practice needs specialized center. So what does that mean? People believe that only if large center and transplant and more 24/7 intensivist and trained people are necessary for ECMO initiation. Is it true? Let's see. If you see the also registry data, the growth of ECMO center across the world has almost like double or triple since 2009, since the H1N1 pandemic, as well as the miniature invention of the ECMO circuit. And then similarly the runs. And now this is 2021 data. If I include 22, it's probably more. And this is also the same. So the concept the ELSO registry is promoting this called the hub and spoke. That means you do not have to have the all the facility available. You can put the patients in a smaller center and transfer to the larger center so that they can be supported and helped. So the idea that you need to have a specialized center is not true. So I believe this is almost my last slide, because I said it's 11. So in conclusion, ECMO plays an important role in modern critical care practice, as I said, because it has many potential role, and we need to be open-minded about its applications, as also open-minded for its complications. What is needed is awareness about its promises as well as pitfalls. What is needed for future, similar to many other field of the medicine, where the precision ECMO patient care model, where we need to be very selective and have a model to predict which patient will be benefit by the ECMO support, whether VV or VA. And we also has to be prepared for the perplexing problem of the practice, which is the ethical distribution of resources, which all of us faced during the ongoing pandemic. With that, I would say that if any of you wanted to join our ECMO course, which is scheduled of November, December, please shoot me emails, and I would stop and take any questions. Thanks for your time.
Thank you, Dr. Guru.